goal. This would be our choice, to try and do a screw retained restoration. All of the items that are in green are positive, all in red are negative. The goal of path of insertion, we now pay attention to during our implant planning. We heard many discussions today from all the doctors who've spoken about planning before the surgery to consider the path of insertion so that we can get a screw retained restoration. That is our goal from the planning. We want to look at where the access opening will be, and then we'll be very, very happy. But all of the green, when one is doing patient care, particularly in a private practice where we want accuracy, we want efficiency, we want productivity and patient happiness, those are all desirable. Aesthetically, the ability to put the margin of the crown and either the titanium collar or the abutment as deep in the sulcus as we want allows us to have more favorable pigmentation in the tissue. In the instance where tissue is thin, if we have a very superficial margin, the graying is unavoidable. And we want to try and avoid that, and we'll discuss it with screw retained restorations. Now, cemented restorations can be useful to correct a path of insertion. There are times when we cannot get a path of insertion. In many cases, for multiple implant restorations, if we are going to do a fixed partial denture, it is impossible to get a path of insertion acceptable. And I'll show you a way around that, but that can be a challenge. And we must use cement. If we use cement, please be very, very, very careful and follow these recommendations. The margin, I will show this several times, must be shallow. One cannot go deep into the sulcus with cement. It cannot happen because the cement itself is a problem. And I'm going to go through that in great detail. The other thing is practically, it is a much slower appointment. A screw retained restoration is usually placed very, very quickly, very, very safely with no problems. It is longer at a cementation visit. The vertical height is different too. We talked about this yesterday at great length. For a cemented restoration, one needs a reasonable amount of height, minimum 7 millimeters, in order to have a crown on top of an abutment. In a smaller restorative space, one can have a satisfactory screw-retained restoration. It's critical. And where will this be most common? In the mandible. I think one of the more difficult places to work is one of the places with excellent bone. The bone in the posterior mandible is ordinarily very dense. The limiting factors are the volume of bone and the anatomical limitation of the inferior alveolar canal and lingual concavity. But the bone itself tends to be very dense, very favorable. The direction of occlusal force is almost straight vertical, so that's very favorable. What's unfavorable is the height of tissue. The connective tissue on the ridge of the lower teeth tends to be very thin, certainly compared to the maxilla. Tissue tends to be deeper and thicker on the maxilla, and the teeth tend to be shorter. And most of the complications that I have seen with implant restorations, other than aesthetic, where the fracture happens or where there's separation of the parts and pieces, it's a short tooth. Short teeth are a challenge, and lower premolars can be a real difficult situation. So we'll look for making our space when we do our plan. We'll place the implant a little bit deeper if we need to, so that we have more restorative space, but we have to keep this in mind because we have limits based upon the materials that we have to choose. Some things we can control, and some things we cannot. So my question always when I'm discussing with dentists is, what is the true cost of doing a procedure? What does it cost the dentist to do a procedure? And the most important thing is the doctor's time. People tend to look at other situations, but if you can do things accurately, and I'll give my impression of occlusion and bites and what we can do to make it easier. It can never be perfect, but can be easier. We want to minimize the amount of chair time and certainly the amount of problems that we have. One of the new advances, and this is extremely important, is the advent of angled screw channel abutments. They're available from several sources, but what this allows a person to do is to have the implant at an angle, but have the access opening to the lingual where we want it. Where is this most common? Maxillary anterior. Why? Because the bone in the maxilla is at an angle. The central incisor for most people is typically overlapping the lowers at an angle. If we add to that the need to move the implant to the palate, as Dr. Town and Dr. Kim mentioned, we often want to preserve buccal bone or increase buccal bone, so the implant will be further and will be tipped, and we will wind up having an increased angle. It's unavoidable. We have to deal with it. The angled screw channel, it says 25 degrees if you read the literature. I'm an engineer, I never want to push the boundaries. I would say 20 degrees when you're doing your planning. And when you're doing your planning for an angled abutment, the good news is the software allows you to place the abutment virtually, so you not only see the axis, but you see the diameter of the hole that you need. So that's very, very important to take into account. This will open up many more options for the maxillary anterior. Just remember, the angle is to the screw, but the restoration still goes in at the angle of the implant. And where that is a problem is extreme angle in thin tissue on a person who shows the gum line when they smile, because the path of insertion has to be the same as the implant. So it's not free, meaning there's always a price to pay when there's an angulation. Why do I like screw retained? I like screw retained restorations. Besides being easy, I'm very lazy. I am the laziest person in the room. And I would like my crowns to come out of the little envelope and go into the patient's mouth like this with no adjustment. But one of the reasons I like the screw retain is this junction, the margin of the crown and the supporting structure. In this case, it's an abutment, a custom milled abutment, but it could be a titanium base, a tie base. That now can be as deep in the sulcus as you wish. This was not always the case. When we started doing these type of restorations, we didn't have that choice. The technology did not exist because we were using porcelain fused to metal. Now with ceramic restorations, which are CAD/CAM or printed, we have the ability to form emergence profile in the restorative material. And getting the restorative material as deep into the sulcus as possible can only be accomplished with screw retained because it is cemented together outside the mouth. If you try to do this in the mouth, it will not work well. And I'll show you why as we get a little further. What I would also like you to appreciate is something that I talked at great length about last year. Some familiar faces may remember, but I want to emphasize this point. If you look at the distal and the mesial surfaces of this restoration, you'll see that they are flat and they are parallel. Before we did the scan or before we took the impression, we go to great lengths to adjust the adjacent teeth to make sure there is a path of insertion. I call it a parking spot, right? One needs a parking place to put your car. The restoration needs a path of insertion. Just as an observation, we started doing this on all our implant restorations, and it's wonderful. It's very successful because we know the path of insertion, and we get very good interproximal contacts, and everything works well. We started doing it for natural teeth. I recommend you do it for everything. Do it for composite resin restorations, do it for natural tooth crowns, certainly do it for implant crowns, and that will make it easier to design interproximal contour and to deliver the restoration because it has a place to fit. The other thing that you should observe, and it was on virtually every case that I saw from my colleagues yesterday and today, is that we all tend to make the interproximal contour in the embrasure space flat. And one of the reasons we make those flat for implant restorations is not to make a contact tighter, but to prevent rotation. As Dr. Lin said, rotation, tipping, all of those things are bad. Screws do not bend. The way you break a wire is you bend it, bend it, bend it, and it breaks. The way you break a screw, bend it, bend it, bend it, it breaks. Twist it, it breaks. No movement. So we can design things to minimize that, and that's part of the design feature when we do something like that. Now, if you must use cement, anybody know this guy? See him from the cartoons? The Beep Beep Roadrunner? That's Wile E. Coyote, my hero. All right, be careful with cement. You may have to use it. Let's discuss cement. Let's talk about it. If you never see this clinically, I will feel good. Unfortunately, some of you have seen this. Some of you may see it. And what we are seeing here is catastrophic loss of bone associated with a small amount of cement. This is what we see. We see a little bit of cement and a lot of destruction. Why? Well, I'll give you my opinion. I'll show you what I believe is the case based on the literature. And you'll hear my conclusion is don't get it there in the first place. Because once it's there, the damage is done. Let me continue. You've seen this picture how many times today and yesterday? When we look at the sulcus and the fibers between the bone and a natural tooth and the bone around an implant and the connective tissue, the seal around a natural tooth is a barrier to cement. If you cement a crown with resin cement on a natural tooth and get excess into the sulcus, it is annoying. It can cause local periodontal problems, but it is not catastrophic if it is removed. With an implant, where the base of this area, this complex, is not fully sealed, if we get penetration from some of the components of the cement, it can progress down the long axis of the implant along the bone interface, because that is not a perfect seal. If you look microscopically at the bone adjacent to an implant, there are spaces. Bone has spaces. Bone has lacunae. There are spaces, windows within the bone. And what we will see is that it can penetrate. I also want to plant one idea for further discussion. When we look at this area, the connective tissue and the adjacent restoration, titanium or zirconia. I'm going to refer to that a little bit later in the presentation, because we know some things now about those interface and how they react with fibroblasts. It's a little bit different. I'll just ask one question. Maybe you can, someone can comment on this. Those of you who have restored implants, have you ever had the occasion to remove a healing abutment and it bleeds? Do you know what I mean? When you take it off, you get a little bit of blood sometimes. Why? What has happened?
Thì hỏi là
The
trong hiện trường này có bạn nào mà bác sĩ nào đã từng tháo hiên linh mà bị chảy máu xung quanh cái hiên linh của lại xung quanh cái hiên linh.
So, let's proceed with this. This is what I had for dinner last night. I'm kidding. That's not what I had for dinner last night. Delicious food. This is the list of components in composite resin cement.
Đây là những thành phần mà có trong cái xi măng dần dần thành hình.
When the contents look like the final exam in chemistry. Right? I don't know if everyone knows all of these chemicals.
Thì thầy không chắc là thầy nhớ hết được tất cả những cái thành phần hóa học này.
I talked about dental materials. Just so you know, the first three
nhưng mà các bạn cần nhớ được ba thành phần đầu tiên trong thành phần của xi măng dần dần.
BisGMA, urethane dimethacrylate, polymethyl methacrylate, things like that. Then there are, forget the one in red for a minute, but then there are other things, other chemicals.
Tạm bỏ qua cái dòng thành phần mà được bổ bảo thì các bạn quan tâm đến những phần phía sau.
Things, and the bottom one is so that it doesn't set up in the bottle before you use it, or the tubes before you use it. But the one in red, TEG-DMA, triethylene glycol methacrylate, is the bad one. It has a high surface energy, which means if you put a drop on an implant, it spreads.
Và cái thành phần này rất dễ dàng có thể lan rộng trong môi trường mà leak ra ngoài.
Put a drop of water, the water beads up because it has very, very low surface energy. With high surface energy, things spread well. Well, this stuff is very spreadable. It's very bad, and it is cytotoxic. It kills bone cells.
Và cái thành phần này nó giết chết tế bào xương.
Why do we have it? I compare composite resin to cheese. If we have a block of cheese,
Nếu
This
các
is
bạn
a nice
đang lấy ví
hard block
dụ
of
về
cheese,
format,
and that's our composite resin. Can we use it for
chúng ta
filling?
có
No,
một
too
khối
stiff.
format.
So you have to make it a little bit softer. The agent that they use to make it softer is
Và
that
cái thành phần mà muốn
TEG-DMA.
để làm
They
cho
add a
cái
little
thành
bit.
phần
It's
xi
like
men nó
adding
mềm hơn,
milk
dễ chảy hơn, dễ
to
thao
the
tác hơn
hard
là cái
cheese.
phần
What
bit
happens? We
GMA
have
về
restorative
DMA.
resin if you add a little bit, right? Restorative resin is still pretty thick. You can't cement the crown, can you? So to cement the crown, what do? Add more, and then you get flowable and resin cement. Now, are those bad for natural teeth? No. Are they bad for sulcus in natural teeth? No, not if you get it out. The problem is the TEG DMA in the flowable resin or in a cement, if it gets into an implant sulcus, instantaneously goes down along the root. And even if the cement is up here, the bad chemicals go down there. So the only solution is to not get it where you don't want it. Let's talk about how we do that. Well, we have to harden it, don't we? Right? How do we harden resins? How do we get them to set? There's three ways. They can have chemicals in them.
Đang nói về cái quá trình chúng ta làm cứng cái resin, làm cứng cái vật liệu dán dính, thì chúng ta có hai cách, hoặc là hóa học.
See if the roof is good today. Right? Or it can have light curing.
Hoặc chúng ta có light curing, có chiếu đèn.
Dual cure.
Hoặc là
I recommend for your implant cases
mà có
khả
năng sử dụng cả hai phương pháp,
I think that will
chiếu
work
đèn
much
và
better.
đông cứng
I
hóa
don't
học.
think you'll have a concern about it. But we want to go from the softer resin to the hard resin very quickly. Well, most of you use a curing light also.
Hầu hết chúng ta sử dụng vật
Does the
liệu
curing
có
light
trùng hợp.
help with implant
Vật
restorations?
liệu chúng ta chiếu đèn thì ở một
Well,
số
the
nhất
answer
thì
to
nó cứng
every
lại.
question is it depends. Sometimes it is, and sometimes it isn't. Let's discuss the porcelain fused to metal crown. How much light goes through a porcelain fused to metal crown? None. So you need chemical cure, correct? How much light goes through a zirconia crown? Very, very little. So light curing a zirconia crown is not necessarily going to get the resin to harden. You have to have the chemical to let it harden. And by waiting, that's when the bad stuff moves. So we want to make sure we minimize the penetration. Now, which kind of cement, which brand? I have no preference. I've had very good success with several. We use the 3M, or we use the Variolink. That Variolink product, the Multi-Link, is designed for crown and bridge. It's designed for implant restorations to be used outside the mouth. Extremely strong. They're all fine. They're both dual cure. But it must be dual cure. And that is different than a veneer cement. Veneer cements for restorations are only light cured because you need more working time in order to place them very critically, remove the excess, and then you shine the light. So if you have two things in the office or two things available, one should be a veneer cement and one should be a dual cure. Right? You don't need a million different products. You just don't. So, what are the rules I said about cement? Cement margins should be at the tissue or very slightly below, but never more than 1 millimeter. Evidence is very clear that once you go beyond 1 millimeter subgingival, the likelihood of having excess cement goes up exponentially, meaning it's twice as bad at 2, 4 times as bad as 3, so you do not want it to go too deeply. And I'd be very, very, very careful. This is one of my early cases. I want to say this case was probably 25 years ago, and we did not have an angled screw channel, and so we cemented the case. Now I would do that with an angled screw channel and correct that. This is something I recommend you use if you cement a crown. If you ever have the unfortunate experience of a loose crown, meaning the screw has come loose, and you have cemented the crown over it, you have to find the hole. We take a picture of every abutment to know where the hole is, and we keep it in the patient's digital chart. We call it the treasure map. And we know where the hole is, so we can go find it later. I make a joke that I like to scuba dive, but not screw dive. Right? That's a bad day when you have to start doing that. Now, this is a product. I wish I owned this, but I don't own this. I have no commercial interest in it. It's IvoClean. IvoClean obviously is made by Ivo Clar, because they have no creativity when they make names. Everything is Ivo something, but it's Ivo Clean. This is a cleaner that is designed specifically for ceramic restorations after you have tried them in the mouth to clean them in order to prepare them for bonding. Zirconia crowns are prepared for bonding by sandblasting. As soon as a zirconia crown is touched by saliva or blood, the bond strength goes down by 50 to 60%. The only way to restore that bond strength for zirconia is to either sandblast it again or clean it with Ivo Clean.
Vấn đề là với phục hình zirconia, các bạn đều biết rằng trước khi gắn phục hình zirconia chúng ta sẽ xử lý bề mặt bằng thổi cát. Tuy nhiên là có một vấn đề là với chúng ta thổi cát xong và thực hiện trong bên đấy thì phục hình của chúng ta có thể bị ngấm nước bọt hoặc thậm chí là máu. Vì việc đấy chúng ta có thể thổi cát lại hoặc xử lý bằng
and they get the silane bonding agent, the coupling agent, but that gets contaminated when you try it in, whether it's natural teeth or implants. If you want to bond, you have to clean. You must clean. And this is the most effective cleaning agent. I'm not aware of any substitute at this point. There may be one that comes on the market, but it's very, very, very effective. And this is one of the few things that the assistants will put the drop right into the crown, because you waste too much if you put it in a dispenser dish. So we drop it right into the crown, rinse it with water, and you're good to go. Very, very, very useful for this, for getting the best bond strength. Now, I talked about cementing a crown and limiting the amount of cement. How can we do this? Well, let's discuss how much cement it takes to get a crown to adhere. The way that crowns are made today is that the lab has an image of your abutment, whether it's virtual or real abutment that they've scanned, and they want to make the crown. They use digital technology to create a space, and that's a cement space. How big is the cement space? The answer to every question, it depends. Typically, for implant restorations, it's 120 microns. It's 120 microns at the occlusal surface, and it tapers off to 0 at the margin over here. Just tapers to 0. But it's 120 microns, pretty much the same for natural teeth. And that's the space. So the volume of the cement is equal to the volume of the cement spacer. So you really don't need much cement, do you? Now, when I went to dental school, faculty fell into one of two groups. When you cement crown and natural teeth, some instructors teach fill the crown to the top, some say line it, and both have good clinical success, right? I don't think there's a significant difference between the two. But for implants, please do not fill the crown. Right? So painting it in is one option. Let's go for another way of doing it. That is the dye, the printed dye that the lab makes when they make the crown. Now, they actually don't use that dye to make the crown anymore. They just use them to sort them and evaluate the crown after it's made. But remember, the dye spacing on our crowns nowadays, whether they're milled or printed, is in the crown. When I went to dental school, the spacer was on the dye. We would paint something on it called dye spacer to create the space. Now it's done digitally. So what we do is we use that little dye, and we take the crown and you put the cement. This is when it's ready to deliver. It's been cleaned. You can see how the inside is nice and frosty. This is an Emax crown. You can see what it looks like. It's ready to go. We put the cement in there. That is dual cure luting cement. Put the cement in, then we put the dye in and wipe off the extra cement, take the crown off and put it in the mouth. And it's got the right amount on the inside. And then you have no problem because you have not put too much. And it doesn't take long. It's very, very easy. Yeah, those of us who've done a bunch know how this saves a lot of time. Those of us who've been faculty, it protects us from students who aren't so experienced. But I do it this way in the office. I recommend it highly. And then we have to get the cement out of the contact before it sets. Please do not take the dental floss and push it through the contact. Where does that push the cement? Down. Put the dental floss under the contact and pull it through. That's very, very important. If you look at this, you want to make sure you direct the cement in the proper location. So, what are we going to say about cementing? If you have to remove it afterwards, please do. And we can use a cavitron, an ultrasonic, or piezo scaler, but you cannot rely on radiographs. If you look at this, I'll show you an X-ray in just a minute. The cements are not adequately radio opaque, and they don't show up. So here's radiograph. I'm going to enlarge that area. You can barely see it. I wish the manufacturers would make the cements more like root canal sealer, endodontic sealer, which has a high amount of barium sulfate, so it shows up, but they won't do it. So the only way to avoid a problem here is to not get the cement, because we know it's going to make damage, plus we know we might not find it. So I would just recommend that you follow those techniques to go ahead and do it that way. So, let me show you another case.
Chúng ta sẽ xem một ca lâm sàng tiếp theo.
Sorry, what happened there? Did I? It just kicked out. Oh, you're going to see the whole presentation again very quickly. Want to go to the very end? Here we go. Perfect. Thank you. That's good. So, do you like this case? Should we do a custom bridge block? Right? This would be okay. All right. This perfect example of the last lecture, correct? But I'm too lazy. This patient had a tumor. For the surgeons in the room, this is the result of a recurrent ameloblastoma. The patient wants no more surgery. Plus, she's had enough. She just doesn't want more. Could we do a block surgery here? Well, we could, but we all know what would be involved. When you have that much vertical height, I don't know. I joke about grafting. My idea of grafting is it's like me. What are the odds on me getting taller? Nah. How about getting shorter and wider? So grafting is good to make things wider. It's not good for making things taller. And that's a fair assessment for grafting. So, what did we do for this patient? We went ahead and placed implants. Look at the angulation on the implants. It doesn't matter. In this edentulous space, it did not matter. As long as the platforms came out to the lingual of the incisors. Then what did I use? The same abutments that we use on a full arch case. Those are universal multi-unit abutments. And if you look at the top, those screws are the screws from impression copings. If you look at the path of insertion of those three, they're certainly not parallel. But if you use the angle corrections, and those are 17 or 30 degrees, and pick the right rotation, look at the direction that you get with a small correction. What do we need to preserve to make it possible to use these clinically? Well, we know that a straight abutment, one of these straight multi-unit abutments, the collar can be 1 millimeter. But to correct an angle, it has to be taller. Typically, the 17 take about 2 millimeters. The 30 degree take 3 to 4 millimeters, depending upon the brand. So you have to make the platform deep enough to do it. And so we were able to take implants at that angle. Now, from an engineering perspective, how strong are those implants with that angulation? Are they stronger or weaker than being parallel? Much stronger. A triangle is the strongest structure you can make. Right? That's just the strongest. So having a bit of an angle like that is very favorable. Go ahead and we'll see what her prosthesis looks like. That's her smile. That is a titanium bar with resin and denture teeth. And she's had that in her mouth for 15 years. And I'm very satisfied. She's thrilled with the result. Absolutely thrilled with the result. You see the space on the gingival for cleaning, for hygiene. We take it out once a year to inspect, but she's extremely happy with that result. So, I think we can do pretty well with our screw retained restorations, and if you're going to do well with cement, take it easy and be careful. Okay? Thank you for this. We'll take a break for a few. I think we're going to take a break, take some questions, and then take a break. Okay? Kate, do we have questions? Okay.
I just wait to question from audience. Câu hỏi gì bạn? Okay. So mình chỉ tóm tắt lại một chút các cái ý mà bài trình bày rất là cơ bản. Đây là cái bài trình bày mà cái sự so sánh giữa cái phù hình bát vít và phù hình xi măng thì chúng ta biết rồi. Thì ông ấy có đưa ra một vài gợi ý về cái giải pháp khi mà phải gắn bằng phù hình gắn xi măng ấy. Thì cái tác hại của cái xi măng dư mà nó nằm ở dưới ở quanh cái vùng mô mềm quanh implant thì nó là một cái mà làm gây tiêu xương như quanh implant, đúng không? Thì cái xi măng có một cái câu mà mình thấy rất hay là tránh dư vật liệu thì tốt hơn là phải loại bỏ vật liệu, đúng không? Thì chúng ta làm cái nào để tránh được dư vật liệu khi gắn trong cái gắn. Thế còn có một cái cách mà quả thật là cách đây 15 năm rồi mình có một cái khóa học ở Đức ấy, thì mình cũng thấy người ta làm rồi, và đấy ông nhắc lại, tức là nhưng mà ngày đấy thì chỉ có một cái abutment manual thôi, analog thôi. Nhưng mà bây giờ thì chúng ta có thể in ra một cái cùi, chúng ta có cái bản số hóa rồi, chúng ta có thể in ra bao nhiêu cùi răng cũng được, hoặc là bao nhiêu cái bản copy của abutment cũng được. Xong rồi chúng ta cho cái phục hình, cho cái vật liệu gắn vào trong cái bản copy đấy để cho nó trào hết cái vật liệu dư ra. Xong rồi sau đấy thì chúng ta, tức là nó còn lại đủ một cái lượng vật liệu ở trong lòng của cái abutment, cái phần mà tiếp xúc với mặt trong của cái sườn ấy, xong chúng ta mới đưa vào cái phục hình phải gắn xi măng, thì cái lượng vật liệu dư gắn dư nó không có còn nữa. Thì đúng là nó theo cái câu là tránh dư vật liệu thì tốt hơn là phải loại bỏ cái vật liệu, đúng không ạ? Thì đấy là mấy cái ý mà cũng tổng kết lại. Cá nhân mình thì thu nhận được mấy cái hay đấy, còn chắc là các bạn cũng nghe sinh viên ở quốc gia là rất là giỏi ngoại ngữ rồi, chắc là các bạn nhặt được rất nhiều những cái ý hay. Ok, các bạn có cái câu hỏi nào khác không ạ? Ok, so please keep continue. Yeah.
If you have any other questions, we'll take no.
Mọi người có câu hỏi nào không ạ?
I'm gonna come back and we have another take a break, and then we have another.
Yeah. Okay. Thank you very much.